All right, Cameron, I'm going to turn it over to you.
All right. So, welcome everybody. My name is Cameron Robinson, and I'm the LGBTQ plus patient navigator with the Grand Rapids LGBTQ plus Healthcare Consortium. Riley Craig, who is our healthcare specialist, will be helping me in the chat today. I wanted to go over a few things before we get started. Just a reminder, the session will be recorded and later uploaded to our website. To protect all attendees and their identities, we will not be posting anything to show attendees or their names. We ask that all questions be put into the chat and then we'll read them to the presenter at the end of their presentation. If you feel compelled to give, we welcome donations to our Give Butter campaign. The donations will be put towards trainings we offer like MedPath mentors and future events. Please feel no obligation, but if you would like to donate, you can visit our website and there will be a donate button in the middle of the homepage. One of us will be dropping the link in the chat if you're receiving CEU credits for this webinar. And again, it'll be dropped in the chat. Now, allow me to introduce you to our presenter today, Suruchi Thakore. Prior to moving to Michigan, Dr. Thakore was the Division Director of the University of Cincinnati Division of Reproductive Endocrinology and Infertility. She is now a physician specializing in I can talk. Specializing in reproductive endocrinology and infertility. And she's looking to, well, since moving to Michigan, she's looking to, sorry, okay. Um, she's looking forward to making a home here in Michigan and continuing helping her patients going through their family planning goals. Now let's move into the presentation. Take it away.
Awesome. Perfect. Hi, everyone. It's very nice to meet you. Like Cameron said, I'm Dr. Suruchi Thakore. I'm one of the physicians here at IVF Michigan and Ohio Fertility Centers. I am based here in Grand Rapids, and so I function as the physician for mostly the west side of Michigan. And I go up to Traverse City as well, so I can kind of have at least we can allow some accessibility to the northern part of the state as well, which is a little harder to get to. So um, I was asked by everyone to come and speak about the fertility side of things and not really like the fertility, can you get pregnant, but how do we get pregnant, especially the special considerations we need to think about in the LGBTQ plus community. So I'm going to be going over a little bit of just basic fertility knowledge and then also the different avenues that we have available to consider. Okay. We're going to rush through a few of this stuff so I can give you guys time to ask questions at the end, but please, if you need me to, tell me to slow down and we'll go from there. Okay. So fertility basics. Now, when we talk about fertility basics, this is in a normal heterosexual couple, just kind of giving us a baseline of what we know from a majority of our literature, right? So the chance of a young, healthy couple who are trying to get pregnant at home per month is only 20 to 25%. Humans are not great at reproducing. And so it's really important to kind of keep that in mind. That's considered our gold standard in a sense. Okay. 1 in 6 couples, and this is all couples, whether they be our heteronormative couples or LGBTQ plus couples, experience some form of infertility for different reasons. Body weight and smoking are the most common reversible causes of infertility and having difficulty getting pregnant. And a woman's age is one of the leading irreversible causes of decreased fertility and having difficulty getting pregnant. So these are things that are really important to kind of keep in mind. Okay. How does age impart a difficulty in this process? Now we need to remember that, the source of the egg, the age of the egg is what helps us determine what the success rate of pregnancy is going to be. So if the female providing the egg or the woman providing the egg is 20 to 30 years old, your chance of getting pregnant every month is around 20 to 25%. However, if you're over 40, that drops significantly to about 5% per month. And so it gets harder and harder the older a woman gets or the eggs get before a person is able to achieve a pregnancy. Okay. After the age of 35, pregnancy rates start to decline. So that's kind of like our fulcrum in a sense when we're talking about for pregnancy rates. Pregnancy rates are pretty good up until about 35, and then they start slowly dropping off after that. Okay, and so they decrease about 15% per year after. Egg quality is affected by age, and that's the biggest reason why pregnancy is difficult the older that a woman gets. We have an increased risk of genetic abnormalities as well, then also leading to increased risk of just miscarriages or failed cycles because of that. And pregnancy complications also increase as the person carrying the pregnancy gets older. So I think that's really important as well to kind of keep in mind. So one of the biggest things that I'm very proud of and definitively affects the LGBTQ community was the definition of infertility. Initially, before 2023, the definition of infertility was truly based on just how long you were trying to get pregnant with intercourse at home. There was no definition of infertility based on other components and other things that may affect your ability to get pregnant. So this was utilized by the insurance companies to really dictate who could get care and also who could get coverage for the additional, more aggressive care that we have. So ASRM, which is the American Society of Reproductive Medicine, they're the ones that define a lot of our just normal day-to-day practices and guidelines, did the definition of infertility to be much more inclusive. So now infertility is a disease, condition, or status characterized by any one of the following: the inability to achieve a pregnancy, achieve a successful pregnancy based on a patient's medical, which is what the old criteria used to be: sexual, reproductive history, age, physical findings, diagnostic testing, or any combination of those, right? The need for medical intervention, including but not limited to the use of donor gametes, which would be donor eggs or sperm, or donor embryos to achieve a successful pregnancy, is also included in this definition. So now we literally are including anyone who ever has wanted to get pregnant into this category, okay? Then they continue to keep the actual timing and duration of attempting pregnancy as well into the definition. If you're less than 35 years old, trying for over 12 months is considered infertility. And then if you're over 35, trying for 6 months is considered infertility if you've not been able to achieve a pregnancy. So what is this special thing that we have to kind of keep in mind with all of this? Sorry, I'm just moving our thing, so I can't see you all in case you need anything, but I can't also read my slides. So I like to think of it as an equation, right? So you need a sperm, you need egg, it needs to incubate in the uterus, and then you need to have a baby. So you need all of these different components to be able to achieve that baby at the end. So the big picture here is, what does your fertility journey need, especially in our LGBTQ individuals or couples? One or more of these components are missing, and we need to be able to fill in the blanks to be able to achieve that end goal of having and building a family. Okay, so we need to determine the source first. Where are these different components going to come from? Are they coming from you or your partner, or which partner? Right, that's important. Are we going to be utilizing a donor for part of this, or will we need who will be carrying the pregnancy? And I have this little reminder here for me to talk about Michigan law later in the presentation, but that would be if you can't carry yourself, if we have a male gay couple, they are going to need a uterus. And so they're going to need a gestational carrier. And there's some caveats to utilizing that, or there were in Michigan, and now it's better. Okay. So where do we get the sperm and eggs, or what do we need to do to determine the ability to use those sperm and eggs, right? So whether it's yourself or a donor, initial testing is essential, right? We want to determine, do we have good numbers? Do we have good counts? Can we predict good quality to be able to then say, yep, easily we should be able to achieve a pregnancy, or it's going to be better than others, right? So the success will depend on only if we have good gametes or not, or good eggs or sperm. So on the egg side of things, we use a parameter called the ovarian reserve. This is basically our how many eggs do you have in your basket? Okay, it's an indirect measure of the number of eggs or oocytes that are available within the ovaries. It gives us a number, and then we use that number to compare what the age group at that level would be. And so then, are you at the 50th percentile? Are you above that? Are you below that? This doesn't tell us that you can't get pregnant or you can get pregnant. It tells us how hard or what manipulations do we need to make to help you achieve a pregnancy. Okay. The best, easiest way to do it, and it's not cycle dependent, it's not time dependent, would be your anti-Müllerian hormone or your AMH test. And so that's done through blood. Okay. So if this is pretty much in the normal range and it's not too concerning, too high or too low, in that scenario, your success rate should be good. Okay. But that doesn't imply quality. So the genetics of the egg to then create the genetics of the embryo, that can only be predicted by the age of the egg or the person creating the egg. Okay. And then if we want to assess the sperm, how do we assess the sperm? That's done through a semen analysis, right? There's multiple different versions of semen analysis out there. The ones that you can get over the counter from the pharmacy or send away, they typically will just tell you, yep, you've got good moving sperm. And they give you just a qualitative assessment. In the fertility world, we really, really want to know the exacts. We want to know how many are there, how are they moving, and do they have a normal shape or not? Because all of those parameters will then help us determine, are we going to be successful or not? Then we want to evaluate the uterus. So whether it's you carrying, your partner carrying, or another individual carrying for you, we need to ensure the baby has a good home. Okay. So the way we do this is we test the inside of the uterus to make sure there's nothing there that would prevent the pregnancy from attaching or growth of the baby. And so this would be like uterine fibroids, polyps, scarring, adhesions, inflammation. These are all different things that we potentially look at. Okay. How do we do this? We want to take a look with a vaginal ultrasound or an abdominal ultrasound, but do an ultrasound of the pelvis. That's the best way to at least document the structures and make sure everything looks okay, right? We're also going to want to do a saline infusion sonogram, which is basically where we put water inside the uterus, or a hysterocontrast sonography, or a hysterosalpingogram. These are all different words to say the same thing. Putting some kind of liquid inside the uterus to assess if that internal part of the uterus is normal or not. The uterus is considered is like a deflated balloon. So once we fill it up, we can blow it up and we can then take a look at that inner part and make sure that that looks normal. Then the last component that we need to assess for and look at is the fallopian tube. So if you're trying to achieve pregnancy, either through home inseminations, office inseminations, timed intercourse, right? You need to have fallopian tubes that function. Those are basically the highway between the ovaries and the uterus. Okay. And that's where the egg and sperm actually meet. So if they don't meet and they can't meet because things are blocking their ability to meet, then pregnancy is not possible with those routes. Okay. So the way that we can test for this is similar to those other tests that we would evaluate the uterus, looking at the water or the dye through the uterus and then also through the tubes to make sure everything is flowing properly. Okay. Once we put all of that story together, then we can say, yeah, we've got a pretty good chance of getting pregnant. It doesn't look like there's anything preventing us from getting pregnant. And then we can put the pieces together and then create that process. However, there's always going to be, even in this scenario where we're not finding anything, 30 to 35% of people or couples will still have what we call unexplained infertility. Okay. Meaning it should be working. Everything is pointing to that it's working, that it should work, but it's not working. And that truly is just because we don't have the ability yet to determine what that is. Is there a fertilization issue? Is there an implantation issue? Are the egg and sperm not meeting even though they think they are? These are all things that we have no ability to test for because you would have to create the pregnancy and then interrupt it to figure out if it's actually working or not. So in that scenario, we don't want to do that. So there's going to always be a big black box of unexplained where we don't exactly know the answer. We can create assumptions and theories of why, but we still may not have a perfect answer. Okay. So then we talk about also the last thing in all of this, and I'm putting this closer to the front because it'll apply to what we're talking about later, is special considerations for our patients with gender dysphoria, right? Gender diverse individuals will sometimes opt for hormonal or surgical interventions to part aid in their gender transition or help them feel more comfortable. This can reversibly and sometimes irreversibly affect their future fertility. So it's really important for us as providers and also for the community to really make sure people understand that there is an option available to freeze eggs and freeze sperm ahead of time so that you can bank it before it's been affected by any hormones or surgery or defining treatments, to be able to then preserve that ability to achieve a pregnancy in the future when that person is ready. Okay, so provides a positive effect not only on your mental well-being, but it also provides a little bit more control of their future and improves the quality of their life as well, because that's one less thing they have to worry about, but they're still able to achieve what they want in their future family. Okay, so that's just kind of something to keep in mind as well. So, what is the process, right? How do we go about doing this? It really kind of depends on, again, that egg plus sperm times uterus equals baby equation, right? We need to figure out where are these components coming from, or if you need to, where are you going to source them from, right? So, couples and individuals with eggs in a uterus, but missing sperm, right? Think of a sperm donor. So, that's somebody who will then voluntarily give up their sperm to help you achieve a pregnancy. This can then be used in an intrauterine insemination, which is basically where we put the sperm inside the uterus, or some individuals will use a home insemination where the sperm is placed in the vagina so that it can get closer to the uterus to achieve a pregnancy. Or we can do, if in these scenarios are not working, or there's something inhibiting the sperm and egg from meeting, requiring in vitro, then a single person within that couple will be able to go through in vitro fertilization, which we'll go through in a little bit, which is a surgical procedure to extract the eggs and then put them together with the sperm to create the pregnancy. Or then there's what we call reciprocal or partner assisted IVF, especially in our same-sex female couples. Okay. This would be then the gestating parent and the genetic parents. Okay, that will be a part of the IVF process, but eggs would come from one of the individual, and then the other partner will then be the one carrying the pregnancy. Okay. In couples with sperm, but missing a uterus and an egg, so our same-sex male couples, in that scenario, you'll need an egg donor. Then we'll need to do in vitro to create the embryos with one or both of the sperm donor or sperm parents, right? To create the embryos. And once we have those embryos, we then need to put them in a uterus to be able to carry the pregnancy. And that's the use of a gestational carrier, or also called a surrogate. Okay. So, third-party reproduction. This is all third-party reproduction. What that basically means is using a third individual to help you achieve a pregnancy. That's donor sperm, donor egg, or a gestational carrier or surrogate. This adds emotional, mental, and physical complexity to the whole baby equation because it's not as simple as just go try and get pregnant and come back and see if it works or not, right? So we have a lot more that we have to juggle and burdens we have to work with during this process. All right. So when you're looking for one of these individuals to be the third person within this equation, right? They can either be identified, meaning you know who that person is, you've chosen that person to be your donor, okay? Or they could be non-identified, basically somebody that's in the old world, we used to call it anonymous, but as you know, with 23andMe and all the genetic testing components out there, nothing is anonymous anymore. Nothing will remain anonymous in the future. So we don't call it anonymous anymore. We call it non-identified. So this is a person you don't know who it is, but you know everything else about them to choose them as your donor. Okay. And likely this can either come through a middle organization like an agency, a fertility center, a sperm bank, or an egg bank. Okay. You really need to be aware. I know cost comes into this, and we will talk a little bit about that towards the end. But we do really want to make sure that we keep in mind that agencies and banks are regulated by the FDA, and it's there for your safety to prevent the risk of infectious disease transmission. So it's really important to make sure that we're not just skipping things along the way. We're doing this, and the reason we recommend this is for your safety and for the safety of the baby. Okay, so all FDA-approved centers must evaluate donors just like you would do a kidney donor, a lung donor, an egg donor, a sperm donor, all equivalent across the board, all thought to be the same because it's all considered tissue. Okay, so the screening and testing to reduce the transmission of infectious disease for any tissue transplantation. All sperm and egg donors must complete a specialized physical exam, a multi-point questionnaire to see if they're at risk for any infectious diseases, and then specialized infectious disease testing through labs that are approved by the FDA. Sperm samples also have the special caveat that they need to be quarantined for 6 months and repeat infectious disease testing be done before we can technically release them. However, in the setting of an identified known donor, you can sign a legal waiver saying you understand the risks of not quarantining it and still move forward with that sperm. Ooh. So egg and sperm donor, egg donor, you can find them either identified or non-identified, like we talked about. The donor goes through IVF to create the eggs. The eggs or oocytes are then fertilized with the desired sperm, and then the embryo is then transferred into the female carrying the pregnancy. In a sperm donor setting, find a donor, either identified or non-identified. The sperm is thawed and then used to create the pregnancy, either through intrauterine inseminations, home inseminations, or IVF. Okay, gestational carriers or surrogates, these are women that carry the pregnancy voluntarily that's not genetically hers or her partner's. Okay, this is the biggest point to keep in mind. The official old version of true surrogacy is where somebody would just go have intercourse or go have sex with somebody, and then their eggs would be used to create the pregnancy. They would carry the pregnancy in their own uterus, and then that baby was theoretically given up as adoption. There are so many legal blurred lines in that the custody battles have been crazy. So we do not in the United States perform true surrogacy medically because there's just way too much. The waters are too muddied in a sense, and there's too many legal battles that need to be fought to then determine whose custody it is. So we don't do that. So our gestational carriers or surrogates are people who are not genetically tied to that pregnancy, but they're just providing their uterus to gestate the pregnancy. Okay. They're always identified because they will usually go through that pregnancy journey with what we call intended parents, or the people who are creating that pregnancy. They need to be at least 21 years old and have delivered a living child previously that's full term. So no pregnancy complications, at least one full term pregnancy. So they don't have a tie or a need to keep that baby. Okay, we can use older gestational carriers, but there is a higher risk of pregnancy complications, and everybody just has to be okay with that. And then things to consider, we also do the same FDA testing as just a good quality standard on all of the gestational carriers to ensure that, one, they're negative before we use them, and two, they're not going to transmit something to the baby. We also want to decrease their risk as much as possible, so the number of deliveries they've had and the type of deliveries are also important. And the last thing here that we talk about in the third party world is embryo donation, right? So this is something that's newer. It's coming kind of on the scene in the sense in the last 5 to 10 years. This is basically extra embryos, because now we're so good at creating those embryos that there's always, not always, but potentially the possibility of having extra embryos left over that a couple no longer needs. And they don't want to throw them away because they have a moral desire not to waste them, but they don't want to also use them to build their family any further. They've completed their family building journey. So what do? They can provide these embryos for donation. It's not considered adoption per se, because that comes with a lot of legal terminology that we don't need to add to the mix, but it's donating the embryos to another individual. So the FDA does not require specific testing in this scenario, but they do recommend that the people providing the embryos go through some testing when they decide they want to donate them. And that's just up to the couple to decide if they want to do it or not. And the way to be matched with these donated embryos can be through individual medical practices like IVF Michigan or other fertility centers, or national organizations. And we can help you kind of navigate that if that's something you're interested in. This means that the embryo that you're going to be using to create a pregnancy is not genetically tied to either one of the individuals or partners within that couple. So we're using a different source altogether. A reason for doing this is because it is a cheaper option than trying to go through the egg donor, sperm donor route. Okay, so that's why some people will choose to do it. Legal considerations. There should be consent for all procedures documented in writing before any of those procedures happen. Each party should have a separate representation to prevent coercion and a conflict of interest. You want to define financial obligations, rights, and responsibilities for all parties, for the intended parents and for the people donating or gestating the pregnancy, and parentage rights. That all should be explicitly written out beforehand. For a gestational carrier, that will also include information on their expected behavior during pregnancy, things they should avoid, prenatal requirements, like going to all your appointments, testing that should be performed during the pregnancy, and fetal reduction and abortion conversations, medical and elective. So then that way, then all of the parties that are involved in this process are on the same page before you even start. It's better to hash out all the problems initially before a baby is in the mix. Okay. Big things that I alluded to before. So Michigan used to call it a felony if you perform just compensated surrogacy contracts in the state of Michigan. So we did altruistic, non-compensated surrogacy. We've been doing that for a while in Michigan, but it's hard to convince someone to go ahead and do a full 10 months of pregnancy and go through all the surgical procedures to implant that embryo before without just for free. It's not something that you easily find. So because of the misdemeanors and the charges that were there, most people didn't perform this in the state of Michigan. However, in March of 2024, the Michigan House and Senate and the governor signed this act into care, the Fertility Health Care Act, which now allows compensated surrogacy. It's not enforceable just yet because of the fact that it still needs to be written out and all the little details need to be created and established. So it's thought to be functional, hopefully at the end of this year, early next year. Okay. But that will then kind of change the landscape of the fertility options in Michigan even more. All right, so last 5 minutes before we're done, just kind of going over really quick what the different treatment options. So what is an intrauterine insemination, right? So an intrauterine insemination is where we watch the ovary, we make sure that the egg is growing properly, figure out when it's about to ovulate, and then insert sperm. Ideally in the office, what we're doing is we're actually getting sperm into the uterus at the top of the uterus instead of it being ejaculated into the vagina or placed in the vagina with a home insemination where it then has to find its way through the vagina, then through the cervix, and then into the uterus. This is already getting placed up and into the uterus itself, so it's 90% of the way there. It just needs to travel down the tubes to find the egg. Okay. Also with the office version, you're getting 10 to 15 times more sperm in the right place at the right time during ovulation as well. So it's a little better controlled. Therefore, our success rates are going to be a little better. So again, gold standard, people just trying at home and getting pregnant, about 20 to 25%. Office intrauterine inseminations, you're looking at success rates of around 15 to 18% because there's always going to be that small other version of infertility that we're just not fixing. And then home intravaginal inseminations, you're looking at around a success rate of around 12 to 15%, but you are going to have to do multiple attempts to be able to achieve that pregnancy. Okay. Then if we needed to go through the IVF route, what does that mean? In a nutshell, it's 10 to 12 days of injectable medications to grow those eggs and override the system so the body makes more than one egg at a time. If we're going to go through this process, we're going to do it right. We're going to get a lot of eggs all at the same time so that we don't have to keep doing it over and over again. Okay. The goal is to force the ovary into creating those eggs. So if you look here at the bottom of the right-hand bottom screen, this is kind of what your ovary is going to look like once we've created all those eggs, and all of those little black circles within the ovary are eggs that are growing. Okay. It takes about 4 to 5 appointments over about a 2 to 2.5 week timeline to grow those eggs. And each appointment will usually include blood work and typically a vaginal ultrasound. Once the eggs are ready, we'll then go in with a surgical procedure through the vagina into the ovary to remove the eggs. There's no abdominal incisions. It's done under anesthesia, so you were fully asleep for it. You don't feel anything. It takes about 10-15 minutes to get all the eggs out from both sides, and then we'll collect them and then give them to the lab. Okay. Once the lab has them, they will then grow them. So if you can see here at the bottom of the screen, this is what an egg looks like. And we've got our little spermies kind of trying to go and get them. Okay. Once it fertilizes, it starts dividing. So this is a 2-cell embryo. It's usually the following day. Then we usually get a cluster of cells. Around day 3, you'll get around 6 to 8 cells. And then as they start merging together and getting more or becoming more, day 4, day 5, we'll start seeing morulas. And then what we call an expanded blast, which is basically an outer ring of cells, an inner mass of cells, and a big hollow space of fluid in the middle that then shows us that that embryo is almost ready to implant. Once we want to implant the embryo, we can then place the embryo similarly to the IUI through the cervix up into the uterus. And we do this under ultrasound to make sure we're placing it in that absolute perfect place that we want it to be. And then typically we can document pregnancy somewhere around 10 to 14 days later. Success rates. So now remember, 20% is the gold standard, right? So after one embryo transfer, if you look at live birth rates per all patients going through all attempts, you're looking at single births of success rate of around 49%, 50%. So that's fantastic now. This used to be lower in the 20s and 30s, even 5-10 years ago. So it's amazing. However, you can see as we get older and we start reaching 40, 41, the success rates start to dwindle substantially, okay? And that truly is because of the quality of the eggs and the embryos that we're achieving, okay? Can fertility or fertility treatments harm the baby? These are all big questions that we always ask. What are the risks, right? So the myth is that if we're taking all these eggs out and we're only supposed to create 1 or 2 in a month, and now we're creating 15 to 20 eggs in 1 month, what does that do to your future fertility? And it does nothing. The ovary normally actually recruits somewhere around 20 to 40 eggs, and only 1 will make it to the end point. During our stimulation, during the IVF process, we're getting many, many more of those eggs to grow all at the same time, and so that they don't get wasted. Okay, so you're not pulling from a bank. Those would have already gone lost that cycle, no matter what anyway. Okay, what are the risks to the individual? Of course, it's a surgical procedure, so you're going to have a risk of the procedure itself, infection, bleeding, those type of things, injury to the other organs around the ovaries, all extremely rare, but we do have to tell you it's a possibility, right? And then ovarian hyperstimulation from the hormones, right? Ideally, we like to get 15 to 20 eggs, anywhere between 10 to 20 is average. But what if we get 30, 40, 50? So that can happen, right? It's rare, but it can happen, and that can make you really sick. Okay. So we need to then kind of watch and moderate that as well. But the best thing is that just kind of resolves by itself. We just have to kind of help you and support you, and then usually your body will take over and take care of it. Okay. What are the risks to the baby? Most babies born with IVF, the risks are very, very low, but we do see it tied to preterm labor, not preterm delivery, preterm labor, low birth weights that then go back up to normal as the kid grows, and then multiple gestations, of course, right? We do everything we possibly can to put only 1 embryo in at a time, create only 1 or 2 eggs at a time, but there's always that risk of making more, and that's where all of our triplets and quints and quads and octomoms kind of come from, right? So we're making nationally a more concerted effort to make this as safe as possible for the person carrying the pregnancy and for the baby itself. Intrinsically, due to IVF, there is an increased risk of birth defects over the general population. Overall, it's about 1.2%, so it's extremely low, but that's still about 1.3 times higher than the general population. Okay. Last, costs, right? Most insurances will cover a consult. So come see me, we'll at least talk it out and hash it out, right? But when it comes to the decision on treatment, only certain companies will cover that. And so it's really important to kind of assess what your insurance does and doesn't cover. If your insurance doesn't cover it nationally, the costs to freeze sperm, for example, $500 to $1,000 per collection, depending on, where that's located and where you're going to get that done. Average costs for egg freezing, you're looking at around $7,000 to $10,000 per attempt, plus some extra medication costs. The average cost of IVF is around $15,000 to $20,000 per attempt. Average cost of using an egg donor IVF gestational carrier, you're looking at $50,000 to $100,000, depending on if your gestational carrier is going to be compensated or not, and if you're using an agency or not. Okay. And then storage costs. So say we create all these eggs, sperm, embryos, and we need to store them. Those are actually the cheapest part of all of this. Okay. Keeping the eggs frozen, embryos frozen is actually very economic compared to the rest of it. Okay. So last thing I want to kind of address is, what are we at IVF Michigan and Ohio Fertility Centers doing to kind of make ourselves as inclusive as possible? Okay. So we truly believe it is our mission statement that every individual has a right to have a child, and every person should be welcome and feel welcome to pursue a family building journey. So it's really imperative that we don't look at people in in regards to what their affiliation is or what their association is or what their ethnicity or their race is. Every person should be able to create a pregnancy. What we're trying to do is just hash out that equation. What do we have? What components of the egg, sperm, uterus do we have? And what do we need to find? And then how do we help you find it? Okay, so we are as inclusive as we possibly can be. We understand that trust is essential to the success of creating a family. And this is in every couple, again, heteronormative or otherwise. This is all couples. Trust is essential. So we do everything we can to guide you through this process and for you to be able to be confident and comfortable that you feel welcome here and that you are in the right place to help you. Okay, so that is our job here at IVF Michigan and Ohio Fertility Centers, is to really navigate you through that fertility journey and make sure that you have all your information that you need to feel comfortable and welcome through that process. Okay, we are, as all medical practices, constantly changing and growing and adjusting our paperwork and adjusting our processes, and we make sure we don't label our bathrooms, we make sure that we don't label our rooms, but the process still will be kind of set up towards vaginal ultrasounds and assessments that we do here in the office more normally on our patients that have ovaries and uteruses, right? But our men are more than welcome to come and join the process, and we do have specialized areas for that as well, for collection of sperm that are, again, de-identified, but also comfortable and inclusive, to make sure that it makes it as easy of a journey as possible for all of our patients. Okay, so that being said, I'm going to stop sharing so I can see my screen here. Anybody have any questions at all that I can answer?
Yeah, thank you so much for that presentation. Lots of insights. We do have a couple questions in the chat. One is, why does Michigan require a guardian of embryos? In Illinois, this is not a thing. Just curious.
A guardian of embryos, I wonder if they could clarify what that means, like guardianship, like somebody has to be like linked to them. In that scenario, the state of Michigan just requires that all tissue that's being stored be linked to or be identified to a specific person. And that could be either a particular couple or it could be a particular individual. But every fertility center, no matter what state you're in, will ask you what we call our disposition, meaning if we're creating eggs and saving them, creating sperm or saving them, or creating embryos, they need to be associated with a person, and that person has to be able to give rights and decisions for that embryo. And if usually the embryo that is equally shared by whoever's creating the egg and the sperm, unless it's a donor and there's special agreements there. So in guardianship, I think if you're asking for why, I think guardianship and parentage are two completely different things, but the state of Michigan and a lot of fertility centers just in general nationally will require those embryos to have somebody that they're affiliated with. So we know who they belong to, who's going to be planning to use them in the future. And also, on the financial side of things, who's going to get the bill for keeping them, right?
Yeah, that was me. So like we did fertility treatment in Illinois,
Okay.
but my sister-in-law did it here, and they had to have like our parents like sign away, like have a notarized letter saying that if something happened to them, they would take over the embryos. So maybe guardianship's not the right word. And we didn't have to sign anything like that in Illinois. So I was just wondering if the law is different. Maybe it's
No,
changed.
it might also be just that particular practice, potentially, or just an extra legal step that they're doing to protect those embryos in case they want them to go one direction versus the other. But I can tell you in that scenario, we at IVF Michigan don't usually require that. That's not something that's required for us.
Okay. It was at the fertility center, which they do things interestingly.
Yeah, so I honestly, I cannot, unless I know that particular scenario and why that physician required it, I can tell you in our paper documentations or our dispositions that the consents that you sign when the creation of the embryo is being made, like before it's made, those consents are our governing documents. We don't usually ask for anything extra or on top of that.
Okay, thanks. That's what we signed in Illinois, was just that. Like the
Exactly.
consent, this is what our, if we both die, here's what we want. Like, yeah. No,
Yeah.
thank you for the clarification.
You're very welcome. No worries. Yeah, I'm sorry. Now that you're explaining a little better, I honestly don't know why that was. I don't have an explanation for that.
We also have another question. Is there a higher success rate if a person had a retrieval at about 32 and does an embryo transfer at 40? Is the success rate that of a 32-year-old or a 40-year-old?
It's a 32-year-old in that particular scenario because it's the age of the egg and when the embryo is created and frozen that determines the success rate of that embryo. It is not the age of the person using the embryo. So it's always better if you're planning for the future to do things earlier than later. This is also not only about the embryo, it's about the eggs, right? So, because that's where it all starts and originates from. So for somebody who is just a single female out there and wants to have a family, but is not ready to start one right now for social, occupational, career advancement reasons, or just not in a relationship where they're comfortable with it yet, freezing your eggs at 31, 32, 33, before 35 will provide you with the best success rates possible for that egg, whether they're fertilized at that point or not. So then you can use those 32-year-old eggs and combine them with sperm and create embryos when you're 40 and then get pregnant when you're 40, and your success rates will be as if you were 32. So that one slide that I had where you saw that drop off of success rates with age, it doesn't matter what age you use the embryo, it's the age that you create the embryo or the egg.
Wow, that's like very fascinating.
Yeah.
We
And
also,
oh, sorry, go ahead.
no, go ahead.
No, I was gonna say, and people always ask me, well, how long can you freeze them for, right? And freezing is, I always like to liken it like sci-fi Austin Powers, if that's your generation, right? It's like what goes in comes out, and that can be 5 years later, it could be 130, like 2 months later, it could be 20 years later. The oldest embryo that's ever been used is over 25 years old, and it was successful at creating a pregnancy.
Wow,
Yeah.
super cool. We have a
Yeah.
comment in the chat that you did a wonderful job, and I definitely agree with that.
Awesome. Thank you so much. I know it's a very overwhelming topic. And so I tried to rush through it fast while still being able to kind of cover all the little nitty-gritty details. But the one thing that I can tell everyone, and the last little parting piece of advice that I have is, if you just even want to know, or if you have any questions at all, you're more than welcome to seek us at the fertility, like at one of our fertility centers locally, or even nationally, wherever you're located, because that, at least getting the knowledge and knowing how to handle that knowledge is so much more important than the actual act of doing it. So we are here to guide you through it, provide you the information you need so that when you're ready, you already know what you're going to be expecting, rather than having to figure it out and then all the stress and anxiety that comes with it all at the same time. Oh,
Okay, we have another one. How do you handle minors who are gender expansive and want to do egg banking or sperm banking before the kids start hormones?
yeah, definitely. No, this is something that we definitely are able to do here. Girl, like those born female need to be menstruating for us to be able to go and get eggs. That unfortunately is necessary. So they have to have started menstruating and gone through puberty. Okay. Otherwise, there's no way for us to access those eggs with the normal treatment options that we have. There are other options of like egg freezing and stuff, or sorry, ovary freezing, where you take out the whole ovary and freeze it, but there aren't very many pregnancies associated with that. That's still considered, it's not experimental, but still very new technology that hasn't really been well fleshed out. And same thing with boys. Boys need to be able to ejaculate a sample, or individuals born male, right, need to be able to ejaculate a sample before they before we can freeze that sperm. But once we get to that point, then typically we will manage them as a consenting minor. They will have to provide assent. They will still need their guardian to kind of approve things and sign legal consent with them. And kind of, we do strongly recommend that they come with a supportive mentor that will help guide them through that process, because they are younger and this can be very overwhelming because they've never done it before. And, they may have never even considered what this entails. But we do manage minors very similarly to all our patients. We guide them through the process. We walk them through it. We teach them what their expectations are and set those expectations ahead of time so that they're as comfortable with this process as possible, because it can be very invasive.
Yeah, thank you. Uh, does anyone have any other questions? All right. It doesn't look like there's any more questions right now.
All right.
Did you have anything more to say?
No, I'm good. Unless there's anything that you want me to add or any questions you want me to, or topics that you need me to kind of flesh out, I'm good. Otherwise, I just wish everybody the best of luck in any family building journey that they choose to pursue. And we're here to help. So come see us.
Yeah, thank you. Yeah, if no further questions, I'm gonna have Cameron close us out.
Good.
What an insightful presentation. I learned so much that I did not know. Um, but thank you so much, Dr. Suruchi Thakore, for your time sharing the service. We appreciate how your work is impacting the LGBTQ plus community. Again, I would like to remind everyone about our Give Butter campaign. Please feel no obligation to give, but if you would like to, we thank you so much for your contribution. If you will be you will be receiving a follow-up email soon after the webinar um, about how you receive your credits and also links to the information. Again, I wanted to remind everyone that this session was recorded and will be uploaded to our website next week. We will have another webinar in August, and the topic will be on non-monogamy. So stay tuned for more information. Thank you so much for everybody for attending.